Welcome in. This is the Red Pill right here on Dash Radio in conjunction with Providence St. Joseph Health. I'm DJ Skee, and we are here today with episode 5 talking about palliative care. Now, I'm joined by Dr. Gonzales and Dr. Vandekieft. Thank you guys for joining us.
Thanks for having us.
Yes, no worries. So first off, for our listeners that may not be familiar, let's start this off with something very basic. What is palliative care? How would you describe that for people that are like, wait, what does that word mean?
Well, palliative care is care that's designed to focus on comfort, quality of life, regardless of the stage of the illness, particularly for people with complex or serious or life-limiting illness.
That's great. And how does this differentiate between, hospice, which might be something that people are more familiar with?
Well, I think that palliative care versus hospice is a really important conversation that we should be having. Most people tend to confuse them. It's something that certainly, even when I talked about this with my own parents, they said, isn't that something that you're just going into to take care of people who are dying? And the reality is that it's far more complex than that. We take care of people across the span of illness, trying to help them to live the best possible quality of life, even while they have something like a cancer.
Yeah, and it's interesting how this often gets overlooked because people will get diagnosed with diseases, and if you've never had that or have never had to deal with that, it's just something that you're like, oh, okay, cool. They just get treatment and hopefully they're okay, or they might not make it, but they don't realize that all the things that go into and the difficulties with treatment, right? Like these things are not easy to deal with, both them, not only for themselves, but for family and everybody else. And plus, keeping yourself comfort. These are very intensive treatments when you're talking, anything for cancer, all these things. And it's about making patients and people comfortable, even if it's not end of life, obviously, for that situation, but even just going through that, and for people that recover, it's still not an easy journey, right?
Well, an easy distinction between hospice and palliative care is hospice is palliative care specific to the end of life, the final 6 months or so of life, whereas palliative care can be provided during active cancer care, during attempted curative treatments. But as you said, there's a large symptom burden that goes along with that. And so having physical symptoms managed, having psychosocial concerns addressed, so we work together with social workers, chaplains, having spiritual care addressed, to look at the whole person as they're going through a complex and difficult illness and its treatment.
It's really important. I think about a woman that I took care of a number of years ago now, and she had stage 1 breast cancer. So really early, will go on to live a very healthy, normal life, but she was having trouble getting through her cancer treatment because it was causing such profound nausea. We saw her in clinic, were able to modify her medications a little bit. She was able to go on and tolerate all of the treatment, and now she's going to live a very healthy, happy life.
Wow. And in all the areas, how did you guys get involved in this? Dr. Gonzales, how did this start? Because you have an interesting story in how, I read something about you from being at Stanford and then working on this database around tailoring treatment for people with HIV, correct?
I did, yeah. So I think the initial reason that I got into this is very personal. When I was 13, my uncle died of HIV/AIDS, and it was really, really hard and really impactful in my life. And I recognized that in watching his illness and watching his sickness and watching his death, that we could do better in trying to take care of people. And ultimately, I thought initially, the way to do this is to fight all diseases. And so I ended up working at Stanford on an HIV database, trying to figure out how we tailor treatments better, how we make HIV treatment better. And while that was really powerful and impactful, I went to med school and thought, this is where I'm going to spend my life. In the end, I recognized, though, that so much of medicine I spend in front of a computer. And that's helpful, right? Like, we need to know what someone's vital signs are, what someone's lab values are, but ultimately, for me, knowing who you are and recognizing the humanity in all of this is so, so important, and that's why I do what I do now.
So it was a family member that went through this care that ultimately got you so focused on specifically dealing with palliative care, right?
Yeah, I think so. The truth is that I ended up sort of being isolated from my uncle when he was really sick. He didn't want me to see him when he was in his dying process. He wanted me to remember him healthy and well, and on some level, I'm thankful for that. I, don't have an image of him really skinny and really wasting away from AIDS, but at the same time, I missed out on some really critical conversations that had I had someone like Gregg or like myself or the people that we work with, our teams, the likelihood is that we would have probably encouraged someone to share that experience with their loved ones and to be there and to be a part of that, because the truth is that sickness and illness is a part of being human.
And that's what's so sad about some of these diseases, especially the way that they've been treated. And why I think one reason that palliative care and taking care of these people is so important, because once that diagnosis hits, oftentimes that they feel like that's the end of them, meaning they don't want people to see them in those conditions, being treated with that, which, again, you're missing out on some of those crucial conversations, and people should be happy while they are here regardless of those things, right?
Well, I think that comes back to the question you asked about separating palliative care from hospice, is that people don't always want to think about these treatments meaning they're dying. They want to focus on living and living life as fully as possible. And so by integrating palliative care early during the treatment of whatever the illness is, to say you don't have to be dying, to have a team that will focus on providing physical symptom relief, that will address the psychosocial complexity of illness, including the financial toxicity of many treatments, and also dealing with the whole person and thinking about the existential or spiritual fears that people address in serious illness.
That's very true. Now, for those listeners out there, when does palliative care actually become a necessity for people? When does that start? At like which level of, I guess if you get sick or anything, is it only for grave diagnoses? Is it only for people that are dying? Like when is this actually, start? When should people start, looking into this?
Well, it's still somewhat a work in progress because it's such a new field. So we do sometimes get referrals that I think could have waited, but more often people wait because they ask, is it necessary, as opposed to would it be beneficial? Yeah. And so many patients undergoing treatment for serious illness maybe don't need the additional palliative care specialists, but they sure would benefit from them. So I encourage referring providers to not ask, do they really need it, but to ask, would it be beneficial? And if they think, yeah, I think it would be helpful, then it's an appropriate referral.
That's very true. Now, the Institute for Human Caring is leading a thing called whole person care. What is that exactly?
So whole person care really, to me, is this sense that we, over the last 10 or 15 years in medicine, have started to think of patients as their list of diagnoses and the list of treatments for those diagnoses. Whole person care is this sense of rebroadening healthcare. It's recognizing that patients are really people, that they're human beings who are fully alive, that have emotions and spiritual needs and psychosocial needs. And whole person care is really about trying to honor all of those things and recognize that that's what makes us human, and healthcare can do a better job of seeing all of those things.
And I might piggyback on that, Matt.
Yeah.
To me, whole person care represents looking at not just the medical elements of care of people, but the social, the psychosocial, the spiritual. People spend very small fragments of their lives truly being a patient. And one of the things I heard from a cancer patient's son that I thought was impressive is when we got involved with palliative care, we stopped thinking of mom as a patient all the time. She went back to being a person, and she was only a patient when she was in getting her chemotherapy or her radiation therapy. And if we can restore that sense of normalcy of living your life as opposed to being a part of the medical industrial complex, we've done the patient and the family a lot of favors.
That's true. Now, in terms of palliative care, how new is this in terms of an area? Because a lot of people might not be familiar with that term. I know when Providence St. Joseph Health brought this up to me, I was like, wait, what is that? And then it's obviously very obvious once you kind of discuss and talk about what that is. But how new is this, I guess, science or this field? Is it something that's been going on forever that we've been ignoring, or is it something that's relatively new?
Palliative care is a relatively new discipline. The general palliative care, people palliate in medical care all the time. That is, they alleviate symptoms. But it was really in the 1990s, people really first in the U.S. started talking about palliative care as a medical specialty. And in the early 2000s, they moved towards eventually forming a recognized medical specialty. And in 2008, it became an official specialty under the American Board of Medical Specialties. When I went through my medical training in the 1980s, palliative care was not a career option. Mm-hmm. And it was as a family physician in the 1990s caring for a lot of people that had palliative care needs that I began to gravitate towards how could I do this as more of a full-time profession. And then the Center to Advance Palliative Care held its first annual meeting in around 2000, and things just really took off from there.
That's awesome.
I would say, I think that because it's so new, honestly, that it's misunderstood.
Yeah.
Not only by patients, by families, but also by other doctors, honestly.
Yeah. Mm-hmm.
So as an example, my parents have a dear friend whose aunt was very sick, and she had dementia, and they were having trouble caring for her, and they were, struggling with financial things and her symptoms, and just trying to figure out how to take the best care of her. And so I said, it would be great if she could see a palliative care team to help her ease her way through all of these potential things that she has, the financial burdens, trying to make sure that all of her symptoms were well controlled. And so my parents' friend honestly went to her aunt's doctor, and her aunt's doctor was like, oh, no, she's not dying. She doesn't need that. Like, we are not there yet. And it was striking to me because I thought, wow, like, this family could be so helped by someone that what we do, and it's just still misunderstood, honestly, which is why it's great that we're talking about it openly here, because I think it's so misunderstood that sometimes people are like, oh, I don't want to talk to you guys because it is
I'm not dying. It's not hospice, which has kind of a negative connotation. Like, as soon as you get to hospice, I mean, the initial general broad thought is that, oh, somebody's going to pass away. This is their last step for what that is, and they probably get these confused a lot, right?
Well, palliative care has been shown to improve quality of physical care, to improve lots of quality outcomes, to improve psychological benefits to the patient and their families, and in many instances, patients actually live longer because their symptom burden is diminished and they avoid those treatments out of desperation that actually shorten their lives. So when I hear other physicians say they're not ready for palliative care yet, my temptation is to say they're not ready to have their symptoms better managed. They're not ready to have less depression and anxiety. They're not ready for their family to have a better outcome. They're not ready to maybe even live longer. Help me understand this not ready business.
It's almost like a joke somebody made. They were like, I wasn't sick until I went to the doctor and he diagnosed me with, X, Y, and Z.
You got it.
It's very similar. Now, for those listeners out there that may be facing this, you never know. I'm sure there's somebody out there that is, facing something where somebody in their family has fell ill, has been diagnosed with a disease or a cancer. What are the next steps for there in terms of even, exploring palliative care and things like that? What should they be doing? Or if this is to happen to them in future, as it inevitably will likely impact everybody over some time in their lifetime, what are those next steps, whether it's you or whether it's somebody else?
When a person's diagnosed with a serious illness, one of the first things they need to do to ask their clinician, what should I expect moving forward? One of the things I hear so often when I ask people, what have you been told to expect, is nobody's told me anything. And unfortunately, the medical community still is not doing that well. So trying to help guide people to be sort of the drivers of their own care and to ask those questions. And then to ask about the symptoms to expect and how are we going to manage them, and are there specialists who can help me manage them? And that will often lead to the discussion of palliative care, and at times that will lead to a referral when they might still be thinking they're not ready for it.
Yeah.
Yeah, I think two things I think of really. One is actually a book that recently came out by Steve Panelat called Life After the Diagnosis. It's an incredible book that is well written and is a little bit of a manual on how to work through having a diagnosis for family members and for yourself, and how to get the support you need. I think palliative care teams can be exceptionally helpful. Unfortunately, there aren't as many of us as there could be. There's a shortage of them. We at Providence St. Joseph Health are really working to expand our ability to provide good palliative care across all of the states that we're in. For those places that we are not, or that you're looking for other options, getpalliativecare.org is a great resource, and it's a independent website that curates all of the palliative care teams and resources really across the country. It's run by the Center to Advance Palliative Care.
How tough is it for people, patients, families, and in your guys' experience to jump in and do that? Because it's almost like, I'm sure the wind gets knocked out of you when you get this diagnosis, and to get up and then be like, all right, let's focus, even if it's something that somebody can get through, that's not in somebody that they have a chance to survive through. How tough is, I guess, taking that first step, and what advice would you have out there? How do you encourage patients, families, everybody else to not just close down, sit there and feel sorry for yourself? Because I don't even know what I would do if I got died. And I've been through that with family members, and you just feel like the world, the rug is pulled from underneath you. There's nothing to do. how do you get up and even take that so you can start doing the research and looking in the sites and going out there, and you can go on and live a happy life, whether it's, getting through a diagnosis until you're clear or until whatever else happens. Up until that point, you should be able to enjoy your life, right? So how do you move from that, the worst thing, I guess, that can probably ever happen and will happen in somebody's life towards, going back and living a comfortable life? How do you encourage patients to see that light and to take those steps?
Two questions I ask that really help me guide patients in that is, first off, to ask, what are you expecting? And find out, are they expecting a cure? Are they expecting to have a lot of pain? What are they expecting? And then a little different framing, when you think about the future, what are you hoping for? And that's much more of an open-ended question, and that helps, again, respond to, we can address those needs with the care that is most appropriate to your goals and hopes. And it's instead of just doing quote-unquote usual care.
Yeah.
And that's part of whole person care, is putting the person with the illness back at the center of the decision-making process, as opposed to trying to pull them into or onto the treadmill of usual care that medicine does.
It's a great point.
I would also say I think it's really important when this happens to be kind to yourself. This is hard stuff, and it's stuff that we don't like to talk about. It's things that we don't want to have to deal with, and so recognizing that it's an emotional time and that you're going to have moments where you're angry or sad or happy that something happened unexpected, and just being kind to yourself and allowing that whole experience to exist is really important.
It's great. This is The Red Pill. I'm DJ Skee. We will be right back with much, much more. Don't go anywhere. We are back with The Red Pill. I am DJ Skee, joined by Doctors Gonzales and Vandekieft. And now we are discussing today, in conjunction with Providence St. Joseph Health, palliative care. Now, we've been talking about a lot of these issues and diagnoses and what the difference is between this and other things like hospice, but I want to know where you guys feel that our health care system has failed patients and their families in certain ways. And you kind of touched on it a second ago, where certain doctors might not be familiar with that, but in your guys' perspective, again, where's our healthcare system fail people specifically in regards to palliative care?
Right now, the way I feel our healthcare system is most doing a disservice to patients and families is the incredible fragmentation. I'm just old enough to remember when a primary care provider worked with a limited group of specialists, and there was a small cadre of healthcare providers that you mostly knew, and they stayed with you over the course of an illness. And now, when a person leaves a hospital, studies have shown they often can't even identify who the attending physician was during their hospital stay. Many times they can't even remember what they were admitted for as their primary diagnosis. We've become so caught up in the care itself and working with the computers and things like that we often lose sight of the person at the center and creating an environment that they can feel cohesiveness, continuity, that sort of thing, and compassion.
I think definitely fragmentation. Folks struggle. It's hard to know who to call when you're at home. Do you call your cancer doctor? Do you call your primary care doctor? Do you call the hospital that discharged you? Sometimes it's hard to know how to network all of those things. I think the other thing, honestly, is communication. We don't do as good of a job as doctors, as a healthcare system in general, communicating in plain, simple terms. It is sometimes hard when you leave a doctor's office, and my own mother will do this. She'll come home and she'll have a list of things that she didn't understand that then she calls me and I'm able to explain to her, which is great that she has me, but that shouldn't happen, right? Yeah. She should be able to leave her doctor's office and have a deep understanding of what's going on with her, because that is her body and it affects her entire life.
And how do you guys feel about the concept that some people say that, modern medical technology has created this chronic illness, and now we only address unintended consequences, that when people are dying badly or in ways that they wouldn't have chosen?
Modern medicine has done many wonderful things. Some of the emerging cancer therapies, the ability to do heart valve procedures through a catheter instead of an open heart surgery. There's a lot of things that have become very beneficial to patients and families. But what we sometimes lose sight of is, what is the big picture? So if we use this emerging cancer therapy, they're still going to have side effects. They're still going to have cancer and progression of the cancer. What are we doing to prepare them in advance? what's happened a lot of times is we say, well, we don't have to use the old school chemotherapy that had many worse symptoms. We can use these newer therapies, and we still don't talk about, but where is this ultimately leading, doctor? And so I think medical schools are doing a better job of training training physicians to think that way, but we're still at a point where patients do need to be their own advocates.
Yeah. And I think too, one other thing that, always strikes me is that we were kind of discussing off air is, with medical technology and stuff, everybody's always diagnosing themselves, looking up worst case scenarios, trying to figure out, even if you get diagnosed, what is next, what is going to happen. And I'm sure when you go search the internet, you'll get a lot of information, good and bad. It's probably the best and the worst thing at the same time. How do you advise your patients in terms of, even if you've been diagnosed or if you're looking for palliative care, like how do you start? How do you get the legit information that's right? Where is your source? Do you go to your doctor and ask them for advice? Do you just do a Google search and go to whatever pops up first? Do we go to Providence St. Joseph Health? Where do you guys recommend, people actually going to kind of explore and see what they should be doing, no matter their circumstances?
That's a really good question, and it's a challenging one, honestly. I think things like Google searches are very helpful because it allows people to get engaged with their own healthcare and to become their own advocates, but it is a little bit of a double-edged sword. I was sort of joking off air that, I've had definitely friends who have texted me and are like, oh, I have a sore throat and I must be dying because I have all these other symptoms that are going along with this. And so it can be challenging to be able to filter through all of that. I think certainly being your own advocate by doing a search, but then going to a trusted medical professional and checking in with them and, being really upfront and honest. I think we all know in the healthcare profession that people are generally Googling things before they've come to see us. And so I think it's on us, to ask a little bit of the question, but if we don't, certainly bring it up and be honest about your own concerns and say, this is what I'm reading, what do you think about this? Because often in these conversations, we tend to sort of talk past each other and not get to the real meat of people's worries, which is important.
Finding a reliable medical website too. So Mayo Clinic, for instance, was a very early entry into what's available on the web for highly reliable information. So encouraging people. I like one of the things Matt commented on though about being mindful to ask patients, what have you found when you've looked this up on the web? Because if we don't ask, often we won't hear it. And I've even heard people doing that now around bereavement with grief and loss at the end of life, because there are many websites popping up around grief and loss, and to ask, what have you found out there? And that can really open up a meaningful conversation as well.
That's great points. Now let's get back to whole person care. What does that look like for you guys at Providence St. Joseph's Health?
Palliative care in Providence St. Joseph Health really began emerging in the 2006-2007 era when a lot of hospitals based that. Whole person care wasn't really talked about a lot yet then. It was talked about some in the primary care world. The idea of whole person care didn't originate with palliative care. A distinction, though, palliative care is very mindful about pulling together a whole team of individuals. We use the term interdisciplinary, which means that you bring the different team members together and they intentionally work together to come up with a shared care plan. That's different than multidisciplinary, where each individual is interfacing with the patient and family, but there isn't that coordinated, mindful approach to a common care plan. So palliative care has really taken the whole concept of interdisciplinary care through multiple providers, physicians, nurses, social workers, chaplains, pharmacists, therapists, into a very new world. Recognizing that the whole person care concept is, that's even more than just medical care. It's about prevention. It's about population health. It's not waiting until illness happens. It's promoting wellness. And so Providence St. Joseph Health, originally Providence Health and Services, created the Providence Institute for Human Caring as a system-wide initiative to say, let's take whole person care, move it throughout the entire healthcare system, and let's even try and move it beyond that and into the communities we serve. And so there's a lot of outreach from the Institute for Human Caring and through our population health divisions to try and think about this as more than just a model of medical care, but really an approach to wellness.
Yeah, I really think we are pushing the boundaries on the idea that illness is not medical, that it's really personal, and that in order to really care for people, we need to honor those things, like the fact is that medical treatment is expensive for folks. And so if there's a struggle in terms of payment, connecting you with resources to be able to help work through that, or to say, wow, like I'm really facing this sense of loss in my life, of loss of dignity. Like we want to make sure that we connect you with somebody who can work through that with you and talk with you. We can't maybe restore independent function. We can't make you walk again necessarily, but we can at least try to work through that with you and help you process that, because those things fundamentally are hard to deal with. And medicine needs to do a much better job of recognizing that affects all of us at many different levels.
It's very true. This is The Red Pill, and we're talking about palliative care. And for those new listeners that might just be joining us and hearing this word for the first time, I just want to kind of go over and reemphasize this. How would you define what palliative care is one more time in quick summary for people that are like, wait, what is this term everybody's talking about?
Well, I think it's a hard word to use, and I wish we had chosen a different word, honestly, as a specialty, because we spend a lot of time trying to define it.
So it's not you if you're out there listening. I didn't even know what this, I was joking earlier, I wasn't familiar with this term when we set the episode up. Then when we start breaking it down, it makes a lot more sense. So
yeah, it's a sense of seeing patients as people.
That's a great way to put it. And it's not just, again, people are like, wait, this is end-of-life care, this is hospice care. No, this is for people that can be diagnosed with something that need a way to deal with that, and as well as for families and people that are dealing with those things. And it's so important trying to figure out what these plans are. And it's a relatively new field as we're talking about. And I think there's a lot of things that need to go on, both patient education and provider education on both elements, right? With you guys at Providence St. Joseph's Health, how are you, I guess, educating doctors and getting people familiar with this new science? And whether it's this and other things as well that are always constantly popping up.
Okay, I'm going to start by going back to just address the word palliative, and then I'll come right
Sure,
back to your
please.
question. The root of the word palliative actually comes from a term that would apply cloaking, the idea of cloaking the physical symptoms a person is having and really embracing them, or putting them, within a safe embrace. In Providence St. Joseph Health, efforts to educate providers regarding palliative care have been fairly extensive. We've held a number of system-wide summits. Folks like Matt and I have been doing a lot of work in our own communities, our own regional and local health systems. But standing palliative care up as its own service line system-wide was really innovative. So we were basically on the same footing as cardiovascular, orthopedics, neurosciences, obstetrics, and mother-baby. And to do that from a health system standpoint was fairly innovative, because most health systems still had palliative care as sort of an adjunct service. Yeah. So to integrate it and say this is a recognized service line gave other providers a sense of, okay, this is a very credible specialty. I need to be more mindful about it and think about how it applies to my practice.
Yeah.
So the other thing I think that we are thinking a lot about is trying to educate our own colleagues about simple things like communication. So for instance, when I went to medical school, which wasn't that long ago, I had a total of 30 minutes of training in communication, which is remarkable and way too short, right?
Yeah.
Spent a lot of time learning how to diagnose things and how to look at slides and all of these things that I don't do in my daily life. The reality is that communication is most of what I do as a doctor, and I spent 30 minutes doing that. So we actually have a class that we've been putting our providers through, our nurses, our chaplains, our social workers. It's 2.5 hours long, taking them through different scenarios, trying to get people practicing this idea of speaking in simple terms and trying to make it easy for us to communicate with patients and families.
It's a very valid point. It kind of gets to the next thing I wanted to discuss about, which is like setting quality standards, meaning that, everybody over 65 should have an advanced directive on file. And these conversations that you have about goals of care, how important and how infrequent do people often, kind of adhere to those things and have, all of their boxes checked? And in terms of when it comes to dealing with patients that are diagnosed and figuring out the strategy for treatment and palliative care, what that is, how involved are they versus the families and people that might not be in this state of mind to make decisions for themselves? How do you deal with that with family and, and assume if they don't have something on file, like what should people be doing out there as well?
Healthcare providers in many specialties have so many boxes they need to check. And so when I talk to primary care doctors about asking about treatment goals, advanced care planning, advanced directives, end-of-life preferences, the first reaction I almost universally get is, I don't have time. Yeah. And part of the challenge is we still operate in a model where the doctor feels like they need to do it all. And one thing that primary care and many other medical specialties are moving toward that I think will be beneficial is more of a team-based model. So much of that work can be done upstream by nurses, social workers, other members of the teams, and then the doctor can kind of enter on second base, so to speak, because first and second have already been taken. And the more we can do to train clinicians how to work as a team and to recognize the scope of practice that their other individuals on the team can do, the more effective it will be.
So in addition to working within our own health system, I think things like this are really important because when you look at national studies of Americans and you say, if you were really seriously ill, would you want to have a conversation with your doctor about what was meaningful and important? 4/5 of Americans say, yes, I would. But it turns out when we look on the other end and say, have you had a conversation when you're seriously ill? It only happens about 10% of the time. And that's a striking disconnect. And maybe this isn't something that we as Americans want to talk about, but we believe as a whole that it's generally important. And so I think that we need to think about changing this conversation and saying that, like, it's a normal, healthy part of being an adult to have a conversation around who would make decisions for you if you were seriously ill. I think a lot of us probably have a sense of who that would be, and we don't talk about that as much as we should.
It's very true. And you hit a good point. One thing that you guys at Providence St. Joseph Health do very well is trying to get these conversations into the community through platforms like us at DASH, which we're very appreciative of. But there's also things like the Right Before I Die exhibit. UCLA has a student engagement program. There's speaking events all over. And part of your guys' job also isn't just seeing patients. You're flying down to experiment with to speak with us, to speak on different gatherings and spread the knowledge of that. How important is that to you guys personally and to Providence St. Joseph Health as a brand in order to, I guess, just better the community, our community as a whole?
Getting the conversations out into the community is essential because, as we commented on earlier, most people spend a very small portion of their lives as patients, and we also want to do a lot of this work before they become a patient so things are already ready. I'm reminded of my 28-year-old daughter calling me out of the blue, "Dad, do I need an advance directive?" Well, where did this question come from, honey? And it turned out that while she was completing insurance and other documents at work, that popped up. So her worker had put into there, do you have a durable power of attorney for healthcare? And so that conversation led into who she would want to make decisions. At 28, it's more likely to be a car accident or something like that as opposed to a serious illness, but it's relevant.
And that's almost more important though, right? Because that's something that if you're in something like that, it's going to happen suddenly. So you're not going to have if you get diagnosed with a disease like cancer at 28, you're likely going to be able to be of state of mind to talk about that. But if you get into, again, like a car accident or something that's impactful, what do you do? And so should that be something that we as listeners, and even me myself, I'm asking is, I guess just a general human being, is that I haven't done that. Is that something that I should go do as soon as we get off air? And also, too, if the answer is yes, which I'm assuming it might be, how do I even do that? Where do I start? Do I need to go see a lawyer and spend money and take time? Or is there an easy way to do this? And I think this is a big question that a lot of people out there have.
I don't know that you need to do an advance directive as soon as we get off air, but figure out when you're going to have a major crisis and can't speak with yourself and do it the day before.
Yeah. Done. Yeah.
But I think that designating a spokesperson like that and then talking to them so they know how you think. I've had patients that say, every minute of biological life is worth it. Keep me on life support as long as you can. That's not the norm, but there are people that want that. And then there are other people that are on the opposite end of the spectrum. I only want comfort care. I'm kind of liking, why only that, even though you're relatively healthy? So having a person who understands your mindset, who thinks the way you do and will be able to essentially represent your voice. I just went through an experience last week with a family member where they said, I don't have to make a decision. I just have to tell you what Dad already decided because he was so clear. I know exactly what he would or wouldn't want right now. And that was a tremendous relief to her because she didn't have to wrestle with that hard decision. She just had to tell us what Dad had already told her.
That's great. How important is this to tell our others, and how do we, again, document this? So it's on, do we need to write this just on a piece of paper and put it in our safe? Like, how does this work? Is it something that we just send an email to that they could do that? Like, what would give, so say if I wanted to give one of you, my rights to that. I'm like, I don't trust my family, blah, blah, blah. I'm going to give it to you. There's different circumstances. How would I go about doing that today?
So it varies state by state, but in general, there are advanced directive documents where you can write down who you would want to make decisions for you. Different states have different laws about how to formalize that document. Some require going to a notary, others require 2 witnesses, whatever the process is, it usually says on the document. We actually have a bunch on our website for all of 7 different states that we're in. So certainly you could go to our website at the Institute for Human Caring to be able to download a document that's very friendly, that's easily accessible. To answer the other question, you don't need a lawyer to do this. And if you change your mind, you just fill out a new one and it invalidates the old one, and then you're able to do the new one. I think it's something that everyone listening really should, at the age of 18, think about. And this is a part of being a healthy adult, and they're not always fun to think about or fun to do. I mean, vaccines aren't that fun, but there's a lot of benefit to it, right? Colonoscopies aren't that fun, but there's a lot of benefit to it. But like ultimately, these things are really important for us to be able to be healthy in our society.
And what should listeners out there be thinking about too? What areas in terms of palliative care, in terms of just everything that we're discussing with these forums and your wishes and in terms of bad scenarios that happen to you, what specific things should we be having conversations about, and when is the right time to have it? Is it when you get sick? Can we avoid and wait? Like, I don't want to think about me having cancer or something, but is that something that I should, all right, if this were to happen, have a conversation with whoever, my family is and people that I discuss that with now? Is that something, or do I need to wait until I'm 65? In your guys' professional opinion, when is the right time for that? Or is it never too early?
Right. There's a saying about advanced care planning, it's always too early until it's too late.
Yeah.
And so I think at the very least, trying to determine who do I want to make decisions for me as a starting point, talking to them and saying, would you be comfortable in that position? And that can start, as Matt said, at age 18. People don't tend to think of it in their 20s, but car accidents happen, bicycle accidents happen, strange illnesses happen. And so planning ahead and then getting that person lined up, that's actually probably the most important first step, and then completing a document, because in most states there's an established hierarchy of who would be your decision maker if you were incapacitated. And so you want to make sure that if it differs, so let's say you're married, but you really want your best friend to be your medical decision maker, you need to have a document to say that, or otherwise, once you're not able to speak for yourself, your spouse has that priority. And then finally, making sure you talk about how you want to live, in that difficult circumstance, what matters most, and that will guide them then to be able to decide which medical treatments would be appropriate and which ones ought to be avoided.
That's a great point.
One of the best resources is actually through one of our partners called the Conversation Project. It's an incredible guide. It's called this Conversation Project Starter Kit. And it's, I don't know, maybe like 8 or 10 pages, and it walks you through some of the practical steps that you might want to take, like pre-thinking, where do I want to have this conversation? Do I want to have it at the dinner table? Do I want to go for a walk? Who do I need to have there? What's important to me? Questions that can help you kind of pre-think through, so that when you have a conversation with somebody that you would want to make decisions for you, you're a little bit more prepared to know what to think about.
That's great.
It comes up in odd circumstances. My 24-year-old son brought it up while we were at the Decemberist concert last month. Dad, if anything, of course, you think about who they have for a dad, but he kind of just brought it up. Dad, I just want you to know, if anything ever happened where you needed to know that somebody needed to take care of you, I'd be willing to do that.
That's awesome.
Where's that coming from, son?
Yeah, right? Does he know something you don't? That's great. Now, in terms of the last thing I want to get before we get to another break is, in terms of palliative care and these, I guess, treatment types of care, sounds like for a lot of people, and I'm sure a lot of listeners out there, especially with already the costs that are going to be ridiculous for just the treatment and the medicine potentially itself, it sounds like it could be very labor and I guess cost intensive. In terms of palliative care, what are the real costs? Is this something that's only available for the top tier people or people with money? Is this something that everybody should be, everybody has access to?
certainly, I think that everyone who needs it should have access to it. I think that, honestly, our biggest challenge is not the cost. Our biggest challenge is there aren't enough palliative care specialists in this country. And so there is a bit of an access issue, but not about who can pay for it. Certainly here in the state of California where we are, it's actually part of the Medi-Cal benefit.
So it's already covered.
It is. The challenge.
This isn't something that people need to go pay for and deal with anything. This is generally, covered as part of their.
It is, and that's one of the great things about it being a new specialty is that it is become an accepted part of medical practice. Honestly, the biggest challenge is finding teams that are available to see folks because oftentimes there just aren't enough of us.
And so is that for people looking for jobs, is there opportunities out there? Is this something that, in terms of, I guess, what, we should be focused on? How long will this take until it becomes more mainstream in your guys' eyes? And I appreciate you guys for pushing this cause and taking the time out of your busy schedules to sit here and share this with all of our listeners. But in terms of next steps and things that we can do, how do we get better and get to that place as a community?
There's a lot of work going on in understanding the palliative care workforce needs better. Clearly within the physician providers, for instance, we are far away from having enough palliative care specialized physicians. So there's study going on, could we come up with alternative training programs where they may not be board certified but could still work in a palliative care practice setting without having the board certification? There's similar work going on. How do we get enough nurses, social workers, chaplains to specialize in palliative care? You asked how long it would take to get there. I honestly can't say. I would say for the foreseeable future, at least a decade ahead, there's tremendous job growth opportunity in the field of palliative care. One of the areas that some of the private insurers are starting to look at is the people they insure want access to palliative care. I talked earlier about all the quality and family and personal benefits from palliative care. But they're also finding that despite the kind of, as you put it, labor-intensive aspect of palliative care, by people choosing what they really want and not just getting on the treadmill of usual care, they frequently choose less expensive interventions. They spend less time hooked up to a lot of life support in the intensive care unit. And I would never want to take that away from a person who has a reasonable chance of recovery. But in America, we've gotten to where you need to have given special permission to not die tethered in an ICU to a lot of equipment. And that's the only way to get that is through advanced care planning. And what many insurers are recognizing is that it can't lead with the economic advantages, but in the long run, we actually spend less. And that's a corollary benefit, not the motivator.
Yeah, it's amazing. It's the Red Pill. I'm DJ Skee. We'll be right back with much more. Don't go anywhere. We are back with the Red Pill in conjunction with Providence St. Joseph Health. I'm DJ Skee, joined by Dr. Gonzales and Dr. Vandekieft. And because this is Dash Radio and we play music, we were just talking off air, and I thought it was important, during this break where we're playing some other songs, to talk about how this has impacted musicians. I mean, notably, recently, David Bowie. Interesting situation, right?
Yeah, so David Bowie's last album was recorded after he knew he had a terminal diagnosis, and much of the content on there really reflects the thought process, the sort of soul searching that he as an artist was going through. And to have an artist to be able to capture that and then crystallize it into his art form and share it with the public is a very special gift.
And I think it's great that, in terms of, even in essence, talking about palliative care, which is basically care, not just for end of life, but for people diagnosed with diseases and things for that, that's probably was a form of care for him mentally to get through that. And I think that's important to look at for every situation being unique and being something that needs to be discussed, that needs to, go through with the team. But I'm sure this brought a sense of relief to him. It was him getting his art form out. And everybody has their own way to do that. It could be painting. It could be enjoying your family, all of that. That was his, right? And you can see that through the songs, which is very interesting, right? How important a role does music play, do you guys feel like? And is there any other examples of artists or situations that you want to discuss?
Well, it might broaden the conversation from music to art in general. I'm thinking here of Dylan Thomas's Villanelle, Do Not Go Gently Into That Good Night, which was written due to his father's dying. Yeah. And he took the opposite tack, which is do not go gently into that good night, rage against the dying of the light, where he felt that fighting all the way through. And that was an essential part of his art, was to put that into poetry and into a unique poetry structure, the Villanelle. I think also of Warren Zevon was diagnosed with lung cancer in his last year of life, recorded an album, The Wind, which has a really remarkable song on it called Keep Me in Your Heart. And they made a documentary of it with Bruce Springsteen and Billy Bob Thornton and others performing with Warren Zevon in his last year of life and sort of reflecting on what he was going through in some of his time with family. There's a certain therapy in that.
Yeah.
And so many programs, part of their work is what they call legacy work. Can we do recordings, audio recordings, video recordings, just putting things on paper that the person really feels is important to express with the time they have remaining and to use it as a legacy for their family. I had one gentleman who, his main priorities, he wanted to write a personal letter to each of his 22 grandchildren. He finished it and died within a few weeks after, but that was a really important meaning-making project for him and his family.
It's incredible. Well, I think we might need to play that record right now.
Okay.
You want to play it? Let's get into it. We'll be right back. We're going to take a short break right here. It's The Red Pill. We are back with Dr. Gonzales and Dr. Vandekieft. I'm DJ Skee. It's The Red Pill in conjunction with Providence St. Joseph's Health. Today, we are talking about palliative care. Thank you guys so much for spending so much time and taking the, even flying down and driving out to take the effort to discuss this with our listeners and hopefully spread awareness for this. So in talking about palliative care, again, for people that haven't tuned in, it's basically figuring out care after you're diagnosed with something, right? And it doesn't necessarily need to be like hospice where it's end of life. It could just be with dealing with something serious and figuring out the best path towards that in terms of comfort, in terms of what your goals are that you want to achieve, and in terms of what next steps are. And it's something that's relatively new that people haven't always, and even within not just, I guess, the community of people, but even within the medical community is still a relatively new field that you guys at Providence St. Joseph Health are really pushing aggressively. And, we need more, as we've discussed through some of the key points that I'm just reiterating, we need more, I guess, providers in there. We need more knowledge and more awareness of it. That's why we're here discussing that. And the last question that I want to get to for you guys is, what does the future of whole person care look like?
Three things I think the future of whole person care will need to include. One is the relationship with broader focus such as population health. That is, how do we look at the health of communities and wellness and promote those things before people get sick so that when they do get sick, there's already infrastructure in place. Second piece is looking into how to broaden palliative care beyond palliative care specialists. How do we have other specialists that deal with advanced care planning, like in primary care, or dealing with serious illness like cancer specialists, heart specialists? How do we enhance their ability to deliver palliative care even before referring to a palliative care specialist? And so we're doing a lot of work within Providence St. Joseph Health to broaden our palliative care education to everyone, not just to palliative care providers. And then I think the third arm of that will be embracing technology as we move into the future. What about non-face-to-face encounters? How do we create things via apps, telehealth, web-based resources that still have high-quality, evidence-based approach to care, but meeting people where they're at instead of always forcing them into our model? An important area for the future of palliative care is telehealth, which is an emerging platform. There are some organizations out there that do it fairly well already. Two examples, ProHealth on Long Island, New York, Resolution Care in Northern California have highly developed telehealth programs. And so within Providence St. Joseph Health, that's become a priority to advance the telepalliative care element. I'm currently involved in a project with the Washington Department of Health where we're piloting consultative services to teams in critical access hospitals in the most remote parts of our state. It's not direct telemedicine. We're not interfacing with patients and families, but we're interfacing with the teams who are providing the care in these small rural communities and providing them consult services and general guidance as they move forward to provide palliative care to people in these areas where access is going to be quite difficult. I expect to see that as a means of delivering palliative care to grow in the future.
That's great. Now, where can people learn more about the organization and specifically the work that you guys do?
So going online to our website at the Institute for Human Caring is, I think, a great resource for patients and families who are facing serious illness or just starting to think about things like, who do I want to help make decisions for me? There are resources around advanced care planning, documents for relevant states that we're in to be able to think through and to walk you through how to make decisions around these things.
It's great. Dr. Gonzales, Dr. Vandekieft, thank you so much for taking the time out and taking the effort to come down here and share this with our listeners. Huge shout out to Providence St. Joseph Health for putting this together and enabling us to spread the word and the positivity of these great causes and great needs to our entire society right here on Dash Radio. With that being said, I'm DJ Skee. We'll be back next time with more on the Red Pill. Until then, you guys have a great day.